Well, it's still early days. We hypothesize that the best evidence for BAL MCF DNA testing is as an adjunctive diagnostic tool for immunocompromised patients with suspected lung infections and for whom bronchoscopy is already being performed as part of the clinical workup. Before diving into MCF DNA testing, I'd like to frame the current state of diagnostics for pneumonia. It always takes me aback a bit, but the true gold standard for diagnosing pneumonia is histopathology with organism identification in tissue. However, we all know that this isn't clinically practicable. It's not feasible, and especially that's true in patients who are thrombocytopenic, hypoxemic, unstable, or otherwise poor candidates for more invasive sampling techniques. In addition, in the immunocompromised patient cohort, they can have infections that are difficult to culture, fastidious, or slow growing, such as molds, nocardia, certain mycobacteria, and other difficult to diagnose opportunistic pathogens. Conventional testing can be very helpful, but culture susceptibilities can take a minimum of 72 hours, if not longer, and results may be negative or inconclusive, especially in the majority of patients who have been pre-treated. These factors all decrease the clinical utility of BAL testing. A 2020 meta-review found that the overall sensitivity of BAL for pneumonia is just shy of 80% at 79.2. So to return to the question, where BAL MCF DNA testing fits into the diagnostic workflow, from a practical standpoint, BAL fluid is already collected in many of these patients as part of the standard evaluation. It's worth considering BAL MCF DNA at the time of the earliest bronchoscopy, at the very least to collect the highest yield specimen. We know microbial cell-free DNA has a short half-life in plasma, and that concentration drops quickly with treatment. Thus, we hypothesize that the yield of BAL MCF DNA testing is likely the highest earlier in infection and before prolonged antimicrobial exposure. Before ordering testing, it is helpful to consider sample handling after collection. Unlike our plasma test, which is collected in a standard PPT tube, BAL samples are often aliquoted and divided amongst the microbiology lab, the cytology lab, and other resources. In our experience, teams that have the highest success with BAL testing have a defined process to ensure successful sample handling, to ensure that they're quickly aliquoted into Streck CP tubes as soon as possible after collection. So to summarize, Focus BAL is a high-value add-on where bronchoscopy is already being performed for suspected pneumonia or lower respiratory tract infection in an immunocompromised patient. It performs best when the differential is broad, conventional diagnostics may be limited, and the results may meaningfully change antimicrobial management or the next diagnostic step.